Parathyroid conditions. The parathyroid glands, normally four, are situated in the neck and embedded in the posterior aspect of the thyroid gland. Parathyroid hormone, or parahormone, is the protein hormone produced by the parathyroid glands, and it regulates calcium and phosphorus metabolism. Increased secretion of parahormone results in increased calcium absorption from the kidney, intestine, and bones, which raises the blood calcium levels. Some actions of this hormone are increased by the presence of vitamin D. Parahormone also tends to lower the blood phosphorus levels. The serum level of ionized calcium regulates the output of parahormone. Increased serum calcium results in decreased parahormone secretion, causing a negative feedback system. Excessive parathyroid hormone levels increase bone resorption, calcium bone loss, by decreasing osteoblastic activity, which is the bone production, and increasing osteoclastic activity, bone destruction. This process releases calcium and phosphate into blood and reduces bone density. Over time, calcium is deposited in soft tissue. The most common cause is benign tumor in one parathyroid gland, resulting in one or more parathyroid glands not responding to that normal feedback of serum calcium. Other causes of hyperparathyroidism include parathyroid adenoma, which is an unusual growth, parathyroid carcinoma, a cancerous lesion, congenital hyperplasia, or so enlarged area, neck trauma or radiation, vitamin D deficiency, chronic kidney disease with hypocalcemia, and then parathyroid hormone secreting carcinomas of the lung, kidney, or GI tract. So those would be cancers of those areas. The patient may have no symptoms or may experience signs and symptoms resulting from involvement of several body systems. Apathy, fatigue, muscle weakness, nausea, vomiting, constipation, hypertension, and cardiac dysrhythmias may occur. All these signs and symptoms are attributable to the increased concentration of calcium in the blood. Psychological manifestations may vary from irritability and neurosis to psychosis caused by the direct effect of calcium on the brain and the nervous system. An increase in calcium produces a decrease in the excitation potential of nerve and muscle tissue. The formation of stones in one or both kidneys related to the increased urinary excretion of calcium and phosphorus is one of the important complications of hyperthyroidism and occurs in 55% of patients with primary hyperparathyroidism. Renal damage results from the precipitation of calcium phosphate in the renal pelvis, which causes renal calculi or kidney stones, obstruction, pyelonephritis, and renal failure. Musculoskeletal symptoms accompanying hyperparathyroidism may be caused by the demineralization of the bones or by bone tumors composed of benign giant cells resulting from overgrowth of osteoclasts. The patient may develop skeletal pain and tenderness, especially of the neck and joints, pain on weight bearing, pathological fractures, deformities, and shortening of body stature. Bone loss attributed to the hyperparathyroidism increases the risk for fracture. The incidence of peptic ulcer and pancreatitis is increased with hyperparathyroidism and may be responsible for many of the GI symptoms that occur. I'm repeating this once again because it's important to know that parathyroid glands maintain calcium and phosphate balance. Serum calcium level is normally maintained within a narrow range. Phosphate levels vary more widely. Increased levels of parathyroid hormone, PTH, act directly on the kidney, causing increased kidney resorption of calcium and increased phosphate excretion. These processes cause hypercalcemia, or excess calcium, and hypophosphatemia, or inadequate phosphate, in a patient with hyperparathyroidism. Assessment includes inquiring about bone fractures related to osteoporosis, weight loss, arthritis, physiological distress, fatigue and lethargy, mental confusion, and even psychosis related to that elevated calcium. Kidney stones from deposits of calcium into soft tissue of the kidney, bone lesions, GI manifestations, usually are anorexia and nausea and vomiting. You can have some epigastric pain because of that elevated serum gastrin levels from the hypercalcemia, which can often also lead to peptic ulcer disease. And constipation is another common complaint. Lab tests always begin with a serum parathyroid hormone level, calcium and phosphate levels, and then your CAMP. I'm not going to even begin to pronounce that. Non-surgical management begins with diuretic and hydration therapies used for the reducing of serum calcium levels in patients who are not candidates for surgery. Usually furosemide or Lasix is that diuretic that increases kidney excretion of calcium, is used together with IV saline in large volumes to promote renal calcium excretion. The priority nursing interventions focus on monitoring and prevention of injury. You monitor cardiac function and intake and output every 2 to 4 hours during hydration therapy. Continuous cardiac monitoring may be needed. Compare recent ECG tracings with the patient's baseline tracings. Especially look for changes in the T waves and QT interval, as well as changes in rate and rhythm. Closely monitor serum calcium levels and immediately report to the healthcare provider any sudden drop. Sudden drops in calcium levels may cause tingling and numbness in the muscles. Preventing injury is important because the patient with chronic hyperparathyroidism often has significant bone density loss and is at risk for pathological fractures. Teach all members of the healthcare team to handle the patient carefully. Use a lift sheet to reposition the patient rather than pulling him or her. Ensure that hospitalized patient is accompanied with ambulating to prevent falls. Drug therapy is used when hydration and furosemide cannot reduce hypercalcemia, or it is necessary to discontinue the IV fluids. Other drugs help reduce the manifestation of hyperparathyroidism, especially those related to hypercalcemia. Oral phosphates inhibit bone resorption and interfere with calcium absorption. IV phosphates are used only when serum calcium levels must be lowered rapidly. Calcitonin decreases the release of skeletal calcium and increases the kidney excretion of calcium. It is not effective when used alone because of its short duration of action. The therapeutic effects are greatly enhanced if calcitonin is given along with glucocorticoids. Some drugs, known as calcium chelators, lower calcium levels by binding or chelating with calcium, which reduces the levels of free calcium. Mithramycin is a cytotoxic agent, is the most effective and potent calcium chelator used to lower serum calcium levels. In most patients, a single IV dose by slow infusion can lower serum calcium levels within 48 hours. However, the toxic effects limit its use to 2 or 3 doses. Thrombocytopenia and kidney and liver toxicity can result after only 1 dose. Liver function studies, blood urea, nitrogen, and creatinine, complete blood cell count, and serum calcium levels are closely monitored in the patient receiving mithramycin. Another calcium chelator is pendramine. Surgical management of hyperparathyroidism is a parathyroidectomy. Before surgery, the patient is stabilized and calcium levels are decreased to near normal. If mithramycin has been used to lower serum calcium levels, studies to determine bleeding and clotting times are needed, as, of course, a CBC to determine bone marrow function. Teach the patient how to perform coughing and deep breathing and instruct him or her to perform them hourly after surgery. Remind the patient that talking may be painful for the first day or 2. Teach about neck support by having the patient place both hands behind the neck to assist in elevating the head. The operative procedure is performed under general anesthesia and involves a transverse incision in the lower neck. All 4 parathyroid glands are examined for enlargement. If a tumor is present on one side but the other side is normal, the surgeon removes the glands containing tumor and leaves the remaining glands on the opposite side intact. If all 4 glands are diseased, they are all removed. After surgery, closely observe the patient for respiratory distress, which may occur from compression of the trachea by hemorrhage or swelling of neck tissues. Ensure that emergency equipment, including suction, oxygen, and tracheotomy equipment, is at the bedside. If severe swelling occurs, the surgeon may need to remove the clips from the incision to preserve the airway. Monitor vital signs, identify any changes in status, and check the neck dressing for abnormal amounts of drainage or bleeding. A small amount, 1 to 5 mils only, of drainage is normal. Hypothyroidism is a rare endocrine disorder in which parathyroid function is decreased. Problems are directly related to a lack of parathyroid hormone secretion or to decreased effectiveness of parathyroid hormone on target tissue. Whether the problem is a lack of parathyroid hormone secretion or of its ineffectiveness, the result is the same, hypocalcemia. Iatrogenic hypoparathyroidism is the most common form and is caused by the removal of all parathyroid tissue during a total thyroidectomy or by deliberate surgical removal of the parathyroid glands. Idiopathic hypoparathyroidism can occur spontaneously. The exact cause is unknown, but an autoimmune basis is suspected. Hypoparathyroidism may occur with other autoimmune disorders such as adrenal insufficiency, hypothyroidism, diabetes mellitus, pernicious anemia, and vitiligo. Hypomagnesemia, is decreased serum magnesium levels may also cause hypoparathyroidism and is seen in alcoholics and in patients with malabsorption syndromes, chronic renal disease, and malnutrition. It causes impairment of the parathyroid secretion and may interfere with the effects of parathyroid on bones, the kidneys, and calcium regulation. Tingling and numbness around the mouth or in the hand and feet reflect mild to moderate hypocalcemia. Severe muscle cramps, spasms of the hands and feet, and seizures with no loss of consciousness or incontinence reflect a more severe hypocalcemia. The patient or family may notice mental changes ranging from irritability to psychosis. Ask about any neck or head surgery or radiation therapy because these treatments may cause hypoparathyroidism. Also determine whether the neck has ever sustained or a serious injury in a car crash or by strangulation. Diagnostic tests for hypoparathyroidism include an EEG, blood tests, and CT. EEG changes revert to normal with correction of hypocalcemia. Serum calcium, phosphate, magnesium, vitamin D, and urine cyclic adenosine monophosphate levels may be used in the diagnostic workup for hypoparathyroidism. The CT scan can show brain calcifications, which indicate chronic hypocalcemia. Nursing care, of course, includes focusing on correcting the cause. So for patients with acute and severe hypocalcemia, IV calcium is given, and then acute vitamin D deficiency is treated with daily vitamin D replacement, and then magnesium sulfate to increase the for the low magnesium level. Long-term therapy for vitamin D is necessary, and nursing management includes teaching about the drug regimen and interventions to reduce anxiety. Teach the patients to eat foods high in calcium but low in phosphorus. Milk, yogurt, and processed cheeses are avoided because of their high phosphorus content. Stress that therapy for hypocalcemia is lifelong. Advise the patient to wear a medical alert bracelet. With adherence to prescribed drug and diet regimen, the calcium level usually remains high enough to prevent a hypocalcemic crisis.